assessment of how successful this spend has been in improving public health outcomes for our residents. We have the report in the agenda, but Lucy, do you want to say just a few words to kick us off?
So firstly, thank you very much for inviting me. I haven't actually been to Overview and Scrutiny to present something before, so it's quite nice that you're sort of expressing interest, which is, again...
I think it's nice at the end of this process.
That's true. It's true. Maybe that's a premature. Thank you. The one thing that obviously I'd want to sort of set a scene around is a lot of what we do in public health is about a long-term investment in health. So I'm pleased that you've obviously looked at the recommendations around the annual report, but and I can talk about some of the changes that we've made as a result of those recommendations. But in relation to assessing the effectiveness of some of those changes, clearly you wouldn't actually see the outcomes change, particularly when we start to talk about children and young people's outcomes for quite some time. So it's just a recognition of the fact that I can talk about some of the actions that we've taken, but we won't necessarily be able to measure some of the impact until a later point in the future.
Okay, thank you. Can I kick it off just first of all by, I suppose it's an obvious one, but can we be reassured that all public health spend is now sort of compliant with the guidelines and the rules and the understanding of Public Health England? Yes. She's nodding.
So obviously, bearing in mind the circumstances under which I became Director of Public Health, it's been one of the things that's been foremost in my mind. We are at a point where we're confident that we are either exiting contracts that have been historically non-compliant or are commissioning new contracts that are fully compliant. So obviously, due to commissioning rules and regulations, etc., some things have had to have contract variations to try and ensure that they do meet the public health outcomes and the grant conditions. But obviously, as I said, Public Health England is aware of those and is happy with the plan that's in place.
Okay, thank you very much. Cecile.
First, maybe before we should maybe congratulate Lucy about her new role, because she's a dual actor too. But first, I would like to say, when I read the report, the very good news is the public health reinvestment into NCC services, because one is active travel to school program, which is essential for obesity and how our young children. And I remember 3 years ago, we wanted a walk to school, and that never get. And also, my pet project, we have the POST program, which for me, it is for our look after children and for family in difficulty. It's a revolutionary program, and it was created, and you must follow, by somebody who was in care, and her mother had 7 children, so she created that idea out of experience, and it's a great, great program, and I am glad. So for me, it's a positive, and as you know, I know a bit more than public health, that may be the average, and I think we are getting from strength to strength. Thank you.
Okay. I mean, obviously, again, at the end of this session, we'll have the opportunity to sort of conclude and, have any commentary that we wish to make. Chris.
Thank you, Chair, and thank you, Lucy, for being here today. So, looking at the report that you've written for us, and you just touched upon it, and it's about the long-term nature of public health spend, and how you won't necessarily see dramatic effects in 1 year, but hopefully we'll see them maybe over 5 years or 10 years or however long the period of time is. Given that, the priorities, I'm assuming, might remain pretty much the same, but the recommendations tend to change year on year. Does that mean that we're in danger of not being long-term enough in our view? And if so, what can we do about that?
So to explain some of the comments I made at the beginning, there are 3 levels of prevention, and apologies if I'm teaching people things that they know already, but primary prevention is about preventing people becoming ill in the first place. So a lot of the things that we do with children, for example, would obviously not see the outcomes for some considerable length of time. Secondary prevention is around mitigating risks that already exist. So, for example, smoking cessation. So people have already undertaken or started on a journey to ill health, and some damage may already have done, but some of that will be reversible or amenable to change. So you can see an almost immediate impact for some of those things. For example, their blood pressure would reduce within hours of them stopping smoking, etc. But the longer term benefits would be they reduce their risk of contracting or developing lung cancer, for example. Then there's tertiary prevention, which has the slightly even more immediate impact, because this is working with people who already have significant disease or disability, but where we still have a responsibility to help them manage their independence and reduce the progression of their disease. So that would be working with people with COPD, for example, to make sure that they are able to physically exercise so that they maintain the lung function that they do have, so that they do get a better quality of life, and hopefully we extend life expectancy, but with a recognition that you will never actually remove the disease burden from that person completely. Again, you will see quite immediate benefits to that. So it depends which level of prevention you're working with. A lot of the NHS organisations tend to focus their prevention obviously on the tertiary element. And so that's why public health tends to focus a lot of its work on the primary and secondary prevention elements. So sometimes there is a more immediate impact. But I do completely understand what you're saying. Each of the annual reports has tended to have a theme for no particular reason other than I think the DPHs historically have tried to make it interesting. The statutory requirement of the Director of Public Health's annual report is actually just to provide you with a snapshot of the health status of the county at one particular point in time. We focused last year, the year before last I should say, when I did an interim report on health protection because it was a particular issue at that point. This year I focused on a much broader area around inequalities, and you're quite right, the investment needs to remain. Where the reason for doing inequalities in part was because of the unitary changes, but also because we'd undertaken a prioritisation process. And it was clear from that that there are significant basic public health services that are not well aligned with our budget use. And that by addressing those, you would be able to start to address the inequalities. You're right in as much as those are highly unlikely to change over time, but what we may want to do is obviously reassess the impact year on year of those services, but also understand how the target populations may change. So overall, for example, if we're developing a more robust weight management service, we may want to revisit it annually to look at the impact of the service, but also to understand as people move in and out of the county if their needs have changed about how they want that service delivered. But also we may want to explore, for example, the use of digital aids to support weight loss. Again, if you'd looked at an annual report or a service specification 5 years ago, it wouldn't have talked about the use of apps, for example, around weight management, or recommendations or creations of blogs, for example, to track people's diary around weight loss. So we need to make sure that as we do reassess things, although they may be the same priorities, we may need to still change our services and the way that they're delivered to ensure they meet need.
Thanks for that, Lucy.
Does it answer your question?
I think so. Okay. I'll let you know in 5 years' time. So, again, reading the report you gave us, and I don't know why it hadn't really struck me before, but it definitely struck me in reading the report, was that there's an awful lot of things that the public health function perhaps is asked or expected to do with not a lot of money. If you did it on a per head basis, 700,000 people, 33 million quid, we're not talking about huge sums of money here. And then when I started to look at, there appeared to me to be 5 statutory obligations. Then in the report last year, there were 8 recommendations. Arising out of that, there are 6 key priorities, each of which has multiple actions. And then further on in your report, there are 9 further priorities, each of which also has multiple actions. Is there a danger that we spread ourselves too thinly, that we try to do too much, that we're not focused enough, especially when, and this may be unfair, but I'll have a look at the page 40 in our pack, the public health budget slide, which, for instance, says that expenditure on smoking cessation is £687,017 in what I'm assuming is the current year. But on page 28, we see that the public health priority was found, number one in Northamptonshire, was found to be smoking, with poor diet and obesity coming in second and third. And then when you have a look at weight management, we're spending less than we are on smoking. Yet, for instance, we're spending, probably absolutely rightly, over £12 million a year on children 0 to 19 services, and I expect that covers a whole multitude of things within. £4.6 million on sexual health, £6.7 million on substance misuse. So, number one, the spreading ourselves too thinly is clearly a danger. Secondly, you've alluded to realigning of spend according to priorities. Would it be fair to conclude there's quite some way to go with the realignment, and that therefore we're going to see quite a lot more of things that we've perhaps seen recently, where some spend in certain areas is withdrawn, which might cause some pain for certain organisations and certain people, so that it can be refocused in the areas that are the priorities? Is that fair?
Absolutely. It's a really good way to summarise where I am. I inherited a directorate that had quite a complex background in relation to its contractual arrangements with providers, its relationship and spend, as you know, between different directorates, and it had a very small staff base. So I think it's fair to say that there was a lot of improvements to be made. You'll see from the beginning that the business plan that covered the last 2 years, this being the second of them, my first priority was about getting the basics right, and that was before Max Caller came and told us that was a challenge for the council overall. Because we don't have the policies, practices and approaches that you would expect to be embedded, or we certainly didn't have in a good public health directorate when I first arrived. Public Health England have been very supportive. They are confident that I'm working compliantly and wherever possible, and they are supportive of us working through our current contract arrangements to make sure that we get to a place where everything is aligned. They've cited the prioritisation work that I've done as best practice, and they have never seen somebody completely align their budgets in the way that I aim to, having used a prioritisation process to identify what the needs are in the county. I don't think I've got the same numbering on the pages as you, so unfortunately, but the public health priorities page, the top 10 health risks was actually from what's called the Global Burden of Disease, which is a World Health Organization approach to identifying the years of disability and years of life lost to risk factors. So that's the profile there in the small box to the left. What I then did was a much more complex prioritisation process, taking the global burden of disease data as well as the public health outcomes framework data. And you're quite right, I have a budget of £34 million and 165 outcomes that public health is meant to influence, and that's just from a monitoring perspective from Public Health England. But I took the adult social care outcomes framework, I took data around inequalities and outcomes around spend and performance for right care, which is sort of the pathway approach that's used in the NHS. I used GIRFT data, which is called Getting It Right First Time, again, which is about making sure that people access services at the earliest point possible to get the best outcomes. We used some model hospitals data, which talks about flows of patients through hospital and the healthcare system, and again identifies outcomes that can be improved from a public health perspective, joint strategic needs assessments that have been done locally, and also health needs assessments that have been commissioned by other directorates, the CCGs and public health. So we used all of that data with the global burden of disease to create the larger table, which, as you quite rightly said, still comes out with the same 2 highest risk factors. The spend that you'll see, well, it's actually our budgets. So last year, for example, although we have a budget of £400,000 for weight management, only £174,000 of it was used because the service currently isn't being provided in a way that people want to access it, and there haven't been appropriate campaigns to motivate people to access weight management services. So that's something that we're addressing this year. Smoking cessation, again, one of the reasons we actually have a budget of 600,000, quite often that's not fully used, again, because people don't engage in those services, or the providers that we've commissioned, some of which, for example, would be GP practices, they don't actively ask their patients if they want to give up smoking, and then they don't have good conversion rates from somebody setting a quit date to actually being a 4-week quitter. So again, we've gone through a process where we've reviewed the efficacy of those services, and they're being commissioned in a completely different way. So our budget for smoking cessation next year is going up to £900,000, and obviously weight management, we're currently out to consultation around what people want, how they want those services to be shaped. We're looking at best evidence in the background, and we will then accordingly allocate a budget that allows, you know, the vast proportion of our population who could have some support losing weight to access services appropriately in a way that they want. So it is a process that will happen over time, and obviously all of that is tangled up in the length of contracts that I'm currently committed to, etc. As I said, we try to make things compliant but also more effective through contract variations, but that is quite a time-consuming process. So I'm hoping by the end of next financial year we will have a much more aligned prioritisation and budget allocation arrangement in place.
Okay. Thank you. There are some in the county that want this committee to focus entirely on the County Council's finances, but of course we are very, very interested in the outcomes for residents. And it is difficult, of course, to the preventative work that public health engages in. It's very difficult to quantify the financial benefits that may or may not lead to, quite often long time in the future, and quite often across wider partners, the health service being one of them, rather than just this council. However, your priorities and how you therefore set your budgets, I am assuming, please say yes to this, that the priorities are health priorities, not financial ones. You know, you want to force your attention at those things that will have the most beneficial effect to people rather than necessarily the most cost-effective way.
Absolutely. So everything that we do is you know, I just gave you a list of the things that we focus on, and it is about the effectiveness of the intervention and health outcomes, and that's the way that we priority set. There are return on investment tools for things like smoking cessation, but you're right, obviously the benefit doesn't come back quite often to the NCC bottom line anyway, so it would be a false approach to actually start to look at return on investment being a driving factor behind that. But we are always seeking value for money, so demonstrable impact from the contracts that we do commission.
Despite our finance remit, I'm reassured to hear that. I've got Michael, then Chris Smith-Haynes.
Thank you, Mr. Chairman. I wouldn't claim to be in any way, shape or form an expert on public health, but I am interested in getting value for money for taxpayers that we represent. We have a budget of £33 million. I'm assuming that the way it's spent conforms to a great extent to a national model from Public Health England. Is that correct?
They have priorities nationally.
And we reflect those priorities, do we?
Not always, because obviously my responsibility is to the residents of Northamptonshire. Yep. So, for example, one of the big priorities for Public Health England would be around antimicrobial resistance, so reducing the inappropriate use of antibiotics. Clearly, that's a remit I can influence, but actually the prescribing responsibility sits with the CCG. So you will see that I influence that through my work with the CCG, but it wouldn't be a budget priority or a work stream priority, because it isn't as much of an issue locally for Northamptonshire compared to things like smoking cessation or weight management.
Right. So
Use your mic, please.
Children's services. Does the percentage of the budget on children's services reflect basically the sort of the national average? Likewise, the second highest spend is on substance abuse. Are we in line with national recommendations here, or how much scope do you have to tweak this budget to specific Northamptonshire needs? I asked my third question at the same time. You might come to that later. I'm interested in outcomes. I'd like to know how you measure the success or achievement level of the way you're spending this money. On certain things like mental health and so on, it's obviously very difficult. But in something like smoking, do we have any figures are over a period of time tracking, for example, the percentage of Northamptonshire residents, perhaps beginning at a certain age, I don't know which age you'd start with these days, and I'm talking about smoking tobacco here, what the figures were, say, 5 years ago, what they were last year, and do you have a target for reducing it next year? Likewise, obesity. We must be able to quantify how many adults, and indeed children, that are categorized as obese. What were those figures, let's say, in the recent past? Do we have any figures? What are they now? And what are you aiming to achieve, spending this money over the next 2 or 3 years, with the caveat that obviously it has to do with partners and other budgets and so on? Is that enough? Okay.
Right, so I have 3 elements to my budget. So statutorily, I have to commission the services that were listed at the front, and they have very explicit elements to it. So, for example, the 0 to 19s public health nursing service is a health visiting and school nursing service. It has very explicit standards around the number of assessments that young children should have in relation to their development, both physical, emotional, and cognitively. And so there is although the budgets will vary from area to area, there's a sort of a relatively ballpark figure that per head of capita that you would expect that service to be, because it's very prescribed, very prescribed. I then have a set of what are called mandated services, so that you have more flexibility. They're an expectation of PHE, but they're not a statutory requirement. But you do have the flexibility to manage them according to need locally, and substance misuse is actually a mandated service. So there is more flexibility in relation to that. And then I have a very small amount of discretionary spend. So, for example, my statutory spend actually is over £12 million. So once I've paid for those services that I statutorily have to commission, £20 million has already gone from a £33 million budget. If you take substance misuse, again, one of the higher spend areas, a mandatory spend, then I'm actually only left with £6.9 million to do all of the other things that we talked about in relation to the risk factors locally. So you can see it's actually a very, very difficult thing to do, and it's the reason that I have to prioritise. Otherwise, I do end up with my budget spread so thinly it has no impact whatsoever. In relation to outcome measures, yes, there are comparisons. So there's something called a spend and outcomes tool, a SPOT tool. So for the mandated and statutory services, it's a 4x4 grid that's available for all councils, and it plots your spend versus your outcomes. So high spend, high outcomes, top left-hand quadrant, low spend but low outcomes, bottom right-hand quadrant. For substance misuse, for example, we are a reasonably high spender, but we have high outcomes. So we're looking at actually it's the second area that internal audit are going to look at for me. They've just done a review of 0 to 19 services, and the second area I've asked them to look at is substance misuse, because I think we can probably maintain the outcomes at the level that we've got, but look for efficiencies within that service. The reason that I'm not able to compare audit findings from this year to previous years is because previous directors have never actually engaged with internal audit for these purposes, and so I have a programme of work now arranged with them to start to be able to provide me and Public Health England and yourselves with some assurance around spend versus outcome. Children's services is comparable, and last week I received for the first time, again my understanding is it's never been requested before, it is a paid for service, but CIPFA have provided me with a complete benchmarking tool against all of the upper tier local authorities around all of the lines of the grant spend. So not just the mandated and statutory services, but all of the discretionary spend as well. Bearing in mind that that's that has its uses, but needs change from area to area. So I may spend more, for example, on smoking cessation because we still have some of the highest smoking rates in the country, whereas other areas, for example, Rutland, may spend very little on their smoking cessation services, and that's entirely appropriate because they have less than 9% smoking rate across the county.
Okay, just to come back to the last point then, which is really the question, measurement of the success of anti-smoking expenditure. Do we have figures for what it was in different parts of the county? I seem to recollect on the Cabinet report that we do get figures on the dashboard of where the hotspots are, which are not surprising. But what seemed to be lacking are the measured number of smokers, well, the estimates of smokers, say 5 years ago, currently, and what the projection is, and likewise obesity. Do you measure obesity?
So smoking, absolutely, because there are national targets set around it. To set a quit date, for a smoker to set a quit date, and then for a 4-week quit, and then for a follow-up at 12 weeks. So, and there's a national tool where you upload that information so you can compare it yourself as a trend over time, but also you can compare yourself to other areas. So we absolutely have that information. I brought a paper to Cabinet a couple of months ago that talked about the fact that there were poor outcomes around our NHS health checks, but also our smoking cessation services, and it's one of the reasons that I've reviewed that contract in its entirety. Both are now going to completely different commissioning models, and as I alluded to earlier, some GPs are more engaged than others. Some will proactively ask people, because they're one of our main community providers around smoking cessation. Some will proactively ask people if they smoke and encourage them to set a quit date. Others don't, but they are still registered as a provider of that service. So there's an inequity around the access to that service as well. So it's not just about outcomes, it's about people even being offered the opportunity to quit. As I said, we've started to look at how effective those GP practices are. We've set a benchmark. Those that don't reach it will have their opportunity to be a level 2 service provider taken away, and our wellbeing advisors will be taking that service on locally because they have a really, really good quit and conversion rate. It's slightly above the national average, but our smoking rates are still above average in certain areas. They are Northampton and some different manual and routine workers in Corby, although Corby has seen a significant reduction in their level of smoking recently because of some more targeted work we've done, but Northampton actually is more of our hotspot now. Sorry, just to answer the question about obesity, at the moment we have a childhood measurement programme that measures childhood obesity at year reception and year 6. And we are seeing an increasing trend, particularly in year 6 levels of obesity. And if you, at the edge of adolescence, are obese, you are quite likely to end up being an obese or overweight adult. So it's a particular area of focus. We also know anecdotally and from the levels of disease and disability associated with people being overweight that Northamptonshire has a problem, but we don't have a routine way of measuring everybody's weight. So that's the more difficult thing for us to track, but certainly where we're engaging in services around weight management, they're showing different levels of effectiveness, again, which is why we've reviewed the service, and with it coming out as a second priority for the county, why we're looking at investing much more money to address that issue.
Okay, thank you. Chris.
Thank you, Chair. I should declare an interest as I've recently accessed the Supporting Independence programme, and so feedback from a patient's perspective is that it was really, really good for signposting and reassurance. However, I did feel that not specifically for me, but for some patients, it might be difficult for them to follow the signposting. It would be easier if there was an ability to refer. And also, I think the social prescribing could be spread out. So, for example, if we look at in Kettering, I believe they've just started the Beat the Streets initiative, which is something that I raised over a year ago when I went on that course. What was the course? I can't remember it. It was Public Health England course. How much engagement is there between public health and the district and boroughs to set up these initiatives, and how do you know who's accessing these services and how can you audit? And yes, is there possibility of engaging with third sector organisations that are focusing on health and well-being so that we can see some input from public health into the social prescribing side of things? Thank you.
So thank you for your feedback around the Supporting Independence programme. I'm glad it was of use. I'll take back the feedback around referrals because there is no reason why they can't refer in. Obviously, it's about promoting the person who uses the services' independence, so you're encouraging them to take ownership of that referral and attendance to whatever they're suggesting you attend. But I do take your point that sometimes people may need a little bit more help, so I'll definitely go and speak to them about that. In relation to the districts and borough services, so you may or may not be aware, it's been quite widely publicised that some of the grant reserve has been used to support the health and wellbeing fora in the boroughs and districts, and most of that the money is being channelled through and the programmes being supported by the borough and district councils themselves, even if they may not actually chair the wellbeing fora themselves. The boroughs and districts have been hugely supportive of this, and it's been really lovely to have an opportunity for public health to support some sort of grassroots health promotion and community development programmes, Beat the Streets being one of them. Beat the Streets obviously is unique in as much as people have a little card, so you register the card, you register information about the person, and then you're able to monitor, because you go and tap your card on different points, how much activity that person's undertaking. So it's unique in as much as it has a natural data capture process sitting behind it. Because N-Sport have been involved in that process as well, we know that we'll be able to join up and use that data. But it'll give us a snapshot of Kettering. There is another Beat the Street that's been supported by Public Health as well. So again, we'll be able to hopefully do some comparisons, but because it's not a universal service, we'll only be able to draw certain conclusions from that data. Obviously, there will be an outcomes report around that, which will focus on the increased levels of activity and people's experience of using that innovation. But it's something that we're really interested in understanding how we can work more with boroughs and districts around use of leisure facilities, for example. People do tend to have membership cards, etc. So there is something about us joining dots up more. But I have to be honest, my focus has been more on getting some of the basics right than it has been on some of that work. But there clearly is a relationship between public health and the boroughs and districts. And I have a representative, a nominated representative for each borough and district that attends that wellbeing fora as well. So one of the benefits of Unitary will be that obviously some of those services are easier to link in. That's not an excuse, it genuinely is something that I haven't got round to, just simply because I've been trying to sort of put some of the basic foundations back in place for the rest of the service. With regard to third sector organisations, public health actually is one of the areas that funds a significant proportion of the voluntary sector services that NCC commissions. And I don't know if you're aware, it sounds like you might not be, but I am leading the development of a social prescribing social impact bond application for the CCG, which is hopefully, assuming it will be supported by the CCG, going to bring in a significant amount of money, so just over £3.5 million into the voluntary sector in Northamptonshire. And the financial committee for the CCG will be making a recommendation whether to support that programme or not in the next 2 weeks, and it will go to the CCG's next governing body. That, as I said, has been completely driven by public health. The focus of that social prescribing impact bond is around 4 cohorts of people with long-term conditions, carers, people who are socially isolated and people with mental health conditions. So we'll have a significant impact on the service use and support available at a very local level for people who use local authority services as well. So I wouldn't underestimate the amount of work that I do with the voluntary sector. Obviously, I'm the current commissioner of the VIN contract as well, and work very closely with Dawn, unfortunately, who is leaving, and David Ward there as well, to help shape the voluntary sector and develop its maturity, because we do recognise recognise it as a significant contributor to our services and to our demand management work that we need to do across all of our services. But it is something that I'm working very hard to develop the maturity of, so that it can demonstrate the value for money that it can potentially provide, and make sure that it's robust and that governance is appropriate.
Thank you for that. I was aware of the involvement with the voluntary sector. You mentioned Dawn. Are you engaging with Sean Silver as well in the north of the county? He's what's the
Groundwork.
word? Groundwork. That's the one. I think it would be useful if you could big yourselves up a bit with regards to the input that you have into the third sector. And identifying, so for example, if you've got someone who's frail, these services are where we're putting our money. Someone who's isolated, these services are where we're putting our money, so that people have got a little bit more of an indicator of where to go to access these services. Okay, thank you.
So I do work with other voluntary sector organisations and infrastructure organisations, and I've been working with George Candler at Northampton Borough Council, Vin and Christoph from Age UK, to look at how we again develop sort of a strategy for community resilience developed by the voluntary sector. There is an understanding that the voluntary sector is important, but it is immature in relation to being a credible provider for some of the services that we require it now to provide, as our acuity of our residents increases, and because of our geography as well, we've got some real rural areas where it can add benefit. But again, we've all got a requirement to demonstrate value for money, etc. And so it's a real balance about trying to develop them and commission them as appropriate, whilst making sure that we obviously think about where we can find alternative sources of funding, because at the moment NCC does fund the lion's share of voluntary sector organisations, and as I said, the social prescribing implementation bond is a real opportunity for the NHS to start to be one of the main commissioners of the voluntary sector as well locally, because they do benefit hugely from the work that they do. And so there's something about the system stepping up and taking collective responsibility for that. So it's nice that you say I should big public health up, but I think that's part of the problem, is actually we've got to take a system-wide view to supporting the voluntary sector and not rely on specific people or sources of income, so that they're much more sustainable in the long term.
Thank you. For other members, the Beat the Street campaign, which has been mentioned, encourages walking and cycling around the whole borough of Kettering, and though it's still too early to know what the outcomes will be, the uptake has been absolutely fantastic, and for a relatively, what I assume is a relatively small cost, it is a really good initiative. Yes, Wendy, you've got...
It was very successful in East Northants. There was a lot of people
I heard that.
Yeah, very successful.
It's about making sure we create a legacy. I think that's the thing. I know that one of the things I spoke to Beat the Streets when they came and spoke to me about the programme was that, for the 6 weeks that they're there, it's absolutely wonderful. Yeah. But particularly coming into winter, how do we get the boroughs and districts and the health and wellbeing for, etc., to continue to encourage and facilitate that physical activity? Because it's quite easy for that to drop off after the 6 weeks. So it's about the legacy as well. So we've got to make sure that we keep talking about how important it is.
Indeed. Councillor Meredith, you wanted to come and make a comment. If you could come and use the microphone, so because we're being webcast, by all means ask a question. Thank you, Dennis.
Firstly, thank you, Chair, for giving me the opportunity of speaking. I'm always very impressed with what Lucy has to say on public health. The last report was actually brilliant, but what I've heard today, unfortunately I haven't had a copy of the report, but what I've heard today has actually been fantastic. I just want to give you a couple of points which I think is important for public health. As you know, in the past I've not been very healthy, but I've managed to get myself back fully fit by going to the gym. I attend the gym 3 times a week, and I do what they call resistance training. Now, I went to the doctors the other day just to have a checkup, and I mentioned to the doctor, and the doctor said to me, he said, now you're going to the gym, you can live longer. He said because it's good for elderly people, and I'm speaking really about for elderly people, about the way that preventive medicine is better than going to the doctors and getting all these tablets and things like that. So what I would like to say to Lucy is I think it would be a good idea if public health could have some sort of liaison with some of these gyms. I know how money is tight, but I'm sure some of these gyms would be very, very happy to put some sort of discount to county council staff to be able to go to gyms, because gyms, especially for the elderly people, are quite expensive. I mean, my membership at the gym is over £40 a month, which is quite a lot for people to find. And perhaps like the Saints Football Club, rugby club, they have a concession where they let their players go. And I was wondering if something similar like that, Lucy, could sort of happen for the county council. And then people, especially of my age and people coming into retirement, if they go to resistance training within the gym, it keeps them healthy, it keeps them supple, and I think it would be a good thing. And thank you very much for your report. It's always brilliant to hear what you have to say, and I'm very impressed.
Thank you, Dennis. A lot of private gyms do offer discounts to larger organisations, but I suggest you shop around. I pay £20 a month. Graham.
Two things. First, a simple thing. On the reinvestment page, there's public health funding for the Domestic Abuse Freedom Programme. That seems to stop, but there is then a domestic abuse prevention service. I just wondered if the second is intended to replace the first and is just an upgrade. But then the second question, and forgive me if this is not actually part of your remit, but I think it is. I think it's key priority number 4, which leads into recommendations 5, 6 and 8. It's all about age adults living healthy lives. Can you, and obviously we've had a lot of publicity about reducing money for daycare centres recently, which are particularly aimed at helping aged adults have healthy life and social inclusion. And I know a bit about, for instance, Glamis Hall, where there is quite an amount of work done to make sure they have healthy lives, good meals, and so on. So can you just give us an update of what's happening there, whether how taking that money away matches with that priority, and particularly as I think there is somewhere, so many pages here, a social well-being 1.74 million for social well-being is in the budget. So can you give us a bit more information on that as well?
So I haven't got my glasses on, which I should have brought to the table with me. So the domestic abuse services, and the other one was the freedom service, which I can't see. So the Freedom Programme was a current programme that was being funded through the Children's Directorate, and there was also a small amount of domestic abuse services being commissioned through adults, and then we were commissioning some, because I had emergency plan and community safety through public health, but it was base budget funded as well. So there were lots of different pots of money around domestic abuse that when we started looking at we had a number of savings workshops, as I'm sure you're aware, over the last year and a half, where we started to look at how we can bring things together to get better value for money. Part of it was about bringing those things, and as certain contracts again ended, it's about creating a pooled resource that has contributions from children's, public health and adults, so that we're commissioning an end-to-end service that goes from prevention all the way through to things like shelter provision for people who need to find a place of safety. So what's happened is that contract's coming to an end and it's being replaced by investment into a pooled arrangement with children's and with adults. It's just a natural end of a contract. Yeah, absolutely. In relation to daycare centres, bearing in mind that obviously the figures that you've got are the budgets, so I'm conscious of the fact that that's really noisy. The figures that you have are the budget allocation at the beginning of this year. So Public Health England had reviewed, as you are aware, certain services that they were made aware of, and there was a panel decision about whether those things were compliant or not. So some of that wellbeing service contract they felt was non-compliant. They didn't review the whole thing. They only reviewed the bits that they were told about, and they were stopped. I've been working with Consortia, who's the provider of that service, because the contract comes to its natural end at the end of March this year anyway, because I think there are elements that aren't as aligned with grant compliance as they could be. My other issue with that contract is the providers have, because there's a number of them, struggled to be able to demonstrate the impact of the work they do from a point of view of public health outcomes and or impact on things like adult social care use. I don't doubt that they all do a wonderful job and that, you know, they're very valuable to the service users. That I've never challenged that. But it's about us being able to demonstrate the value for money and the impact that they have. And then obviously, when you look at the rest of the funding that's there, we've just, as you know, rearranged how the wellbeing advisors work. So we've created the Supporting Independence programme. So those wellbeing advisors that are significantly trained to manage, assess and manage mild to moderate frailty, it's nearly £1 million worth of resource. So they are already able to demonstrate the impact that they've had in relation to avoiding hospital admissions, etc. So if I'm going through a process of prioritising spend on a typically reducing budget, I'm going to use the evidence base and the performance information that I have to make assessments about where money needs to go in the long term. We are meeting with all the providers for the social wellbeing contract tomorrow evening to look at how we can better understand the impact that they do have. And this is in part reflected by my comment earlier about their maturity in relation to being able to demonstrate value for money in the services that they provide. And we'll be looking at how we can arrange a sort of a bridging exit year. But again, I've got financial constraints and other priorities that need funding as well. So it's about balancing all of those things. I mean, Chris very succinctly summarised things earlier that, you know, public health historically has, and I think, you know, I am still at risk if we aren't robust in what we do, spread the money too thinly to be able to have a demonstrable impact.
So I'm pleased you're meeting them. I mean, I've seen the monitoring report, for instance, the Borough Council does with GLAMS, and there are some, you know, very good figures in there and some useful information. Perhaps they might share it with you. So does that mean that if they're able to demonstrate impact and, you know, valuable evidence-based impact, that there is some wriggle room, some room in your budget to fund appropriately where there is? I mean, so I don't know them all, and I suspect some of them have probably got better funding than others. But is that something that you're going to be able to look at, maybe using your advisor you just talked about to be a conduit with them?
So at the moment, through the prioritisation process, as I said, we've quite rightly said that we've got some significant challenges where there isn't adequate budget, and we're going through a process of consultation and needs assessment to identify what resources needs to be allocated to things like weight management, etc. So what's available for other services will in part be dictated by the cost of what we think that service is going to be in going forwards. There will, I think, be money left, and I've spoken to Consortia about the fact that I have a duty to address inequalities across the system as well. That is a huge remit, as I'm sure you'll appreciate. So what we need to do, again, is use the evidence that we have to say, well, OK, which populations in particular would we want to work with, be them physical geographies, because we know that some of our wards and our boroughs and districts are more deprived and therefore more likely to have residents that suffer from inequalities than others. Or it might be specific cohorts of people, for example, the homeless, older population. It could be Gypsy and Roma in traveller communities. It could be young parents. You know, there's lots of groups of people who also suffer from inequalities and currently don't have any services. So once I'm able to profile what we need to address the initial priorities that currently are significantly underfunded, we'll look at how we create an inequalities programme and how best that is provided. Again, I have requirements to meet procurement legislation, so that will need to go out to tender, etc. You will need to have consultation around all of those things, as we would with any contract, whether it's VCSE sector-led or led by any other sector. And again, I have a duty to demonstrate value for money around that. So hopefully the way forward will be a little bit clearer after our meeting tomorrow evening. But there is no doubt that under these circumstances, as the Council is well aware, not just in relation to the public health budget, but all of our budgets, there isn't enough money to do everything, and therefore we have to use a process whereby we prioritise our spend and always seek assurance that we're getting what we need from any money that we spend.
Thank you. I've got Julie and then Jane, and if we could keep as much as we can the questions and answers as brief as possible, so then I want to try and conclude this part of the session. Julie.
Thank you. I do appreciate, the budget pressures that you have to work under, and I think it is quite sad. And like Graham says, the day centres or community centres and different services that we did have that have had to go because of budget pressures are now showing that they were actually really needed, because you have the unintended consequences. In sheltered housing, say for the elderly, the fact that because they no longer have the community centre, they no longer have wardens, they become very isolated, their health suffers, anxiety, depression, which may then go over to the doctors, but it's still a pressure on, the tax that we pay. So I wondered how, because I'm talking about older people here, how closely do you work with adult social care in respect of that? Because what I hear from older people is that they feel forgotten and just left there because there's no one seeing them every day, and they are feeling depressed, and some of them say, well, I'm just sitting here all day, and if I could have physiotherapy and some help, then I could become more independent. So I don't really understand as much as Chris does the Supporting Independence programme, but I wondered how that comes in there, please.
So the Supporting Independence programme, as I said, is a public health funded programme. Again, it's sort of secondary and tertiary prevention to make sure that people remain as independent as possible for as long as possible. Because on the continuum of care, obviously I have requirements around my budget that stop me spending it on things like adult social care interventions, and that's exactly the issue that was obviously identified as historically having happened. So there is a sort of a line which is slightly blurred between where responsibility around public health starts and stops and adult social care starts and stops. The social wellbeing contract was obviously historically funded by adult social care and was brought across by a previous Director of Public Health under public health. So it's obviously one of the reasons that I'm trying to make sure that whatever we commission going forwards is appropriately aligned with need and also appropriately aligned with the grant compliance criteria. That's not to say, as I said, that it's not a needed service, and I recognise social isolation is a big issue, and that's one of the reasons it's one of the 4 areas of focus of the social prescribing implementation bond that I'm trying to get commissioned through the CCG with system support. So for me, it's about making sure that public health works with partners who have statutory and non-statutory responsibility for commissioning and providing services to make sure that we're collectively ensuring our money is spent in the most appropriate way and in the most compliant way. So I think if you're talking about sheltered housing, obviously the responsibility to manage that goes across housing in boroughs and districts, adult social care, probably children's in part because they may be learning disabilities, people housed in similar housing, again, public health around inequality. So it's a collective responsibility. And what I'm trying to do with the social wellbeing contract as we review it and review need going forward is then looking for people to take collective responsibility to support the identified ongoing needs.
It's not just sheltered health, and obviously there's elderly people, yes. So if they want the physiotherapy for them to become independent, and if they need counselling to help, that would then just go across to the GP, would it?
So physiotherapy is typically an NHS referral process. So yes, usually you would need to see your GP to be referred to a physiotherapist. GPs are starting to have what are called first contact physiotherapists from next year onwards as part of the new PCN arrangements. So people should be able to speak to the receptionist and they would be triaged through a process. And if they had a more musculoskeletal physical activity need, rather than seeing the GP at all, they'd go straight to the physiotherapist. So there's a recognition in the health system that people need easier access to the multidisciplinary team, not always to have to go through the GP. It's not the best use of the GP's time, nor yours, to have 2 appointments. I'm working with adult social care to try and make sure that we're linked up in what we do. So where we've started to look at how we provide much better multidisciplinary team responses to community need. The Supporting Independence programme has worked alongside the reablement teams with adult social care and the primary care district nursing teams to start to pull together programmes that look at the holistic needs and also make sure that they're signposted to the most appropriate service. Some will only need some low-level support that can be provided through SIP. Others will need something like reablement with a trained district nurse involved. So it's making sure that people's needs are assessed appropriately. So we're trying to align our service provision that way. So we're working much more closely with adult social care in that respect.
Thank you very much, and I do desperately want to try and bring this to a close now. Jane, you did indicate.
Right. Quick question, Lucy. Could you tell me where your Domestic Abuse Freedom Programme fund was directed and also the Domestic Abuse Prevention Services for 2019 and 20? Where do they end up? Because obviously, the police funds, the police funding goes into Voice and Sunflower. Where does your fund end up? Thank you.
So the Freedom Programme was something that we took on as children's services were at a point where they had to disinvest in it. So it was the programme that was inherited from children's education and CFE. Children's, Families and Education, thank you. So it didn't change its remit from what had previously been set, and the new programme is still being scoped with the police, funnily enough. We've met with the OPCC's office, and Matt Hoy has been looking at how that's developed because he looks after community safety. So the investment is from public health alongside adults and children's, but the whole programme is being shaped as a system. So I have to be honest, I'm not close enough to the detail to tell you exactly what that's going to look like in the long term. But I can find out for you.
Could you, because
absolutely.
Funding for organisations such as the Northamptonshire Domestic Abuse Service is crucial, and the work they do is extraordinarily effective.
Could you use your mic, please, unless you finished?
Oh, sorry, I thought I was. It's NDAS is a organisation that's incredibly effective, but they seem to miss out on all these funding pots, whereas they go to...
You can respond in detail to Councillor Birch. Yep, okay, excellent. In that case, committee, I'd like to bring this particular session to a close. Any conclusions, anything we want to do, anything we want to say, any further information, any further scrutiny? I'm in your hands. Thank you very much for your time. Appreciate that. Yeah, note the report and appreciate the answers. Right, we've got 2 item agendas. The last one, the work programme, is going to take about 3 seconds, hopefully. We have, before that though, item, where are we? 8, thank you, which is a a hangover from our last meeting where we wanted further information from Children's Services before we reached any conclusions around the placements issue, and we need to decide whether there's any commentary, any recommendations, anything we want to send to the Executive. Any further scrutiny required? Victoria, kick us off.
Just very quickly on this, because we've had a lot of change at the moment in children, so we've got an interim director, we've got new commissioners coming in tomorrow, so there's a lot of conversations and dialogue to be had, could we just put this back to the next meeting to get a more robust update, because Cathy Hadley, who's the Assistant Director in charge of placements, is now Interim Director of Children's Services, and I just think we'd get a clearer picture if we can just let that settle for 4 weeks for those new people to come in, if that's okay, just in my opinion.
On children's services at the next committee.
Okay, so you want an item of some sort on children, so you want Cathy perhaps to come and...
Well, I think it would depend on... It's very, very busy at the moment, but I mean, I'm happy to act as a conduit or ask Fiona to come in and give an update if Cathy can't.
Let's agree the principle of that. Let's sort out the detail at our pre-agenda meeting. Is everybody happy with that? Okay, great. Next item, work programme. I'm going to ask James to introduce this item. I would strongly suggest that we discuss it in detail at the pre-agenda meeting, which is what we should do. And before I bring James in, just to say any comments then, get your diary out before you rush off, Julie. I just want to, sorry, Victoria, just confirm dates for your diary. The pre-meeting will be 6th of November, 10 o'clock. The committee meeting for next month will be the 27th of November, 10 o'clock. But before then, of course, we also have the Cabinet meeting on the 12th, which means that we will be meeting anybody that wants to informally to discuss the monthly finance report to Cabinet on Friday the 8th. Can I suggest that that is in the morning, if possible? Well, I know I'm not available in the afternoon, so I'll ask James if you wouldn't mind to book a room for Friday the 8th in the morning and circulate, and then anybody that can come. And of course, if you can't, you can pass on any comments beforehand. And the only other thing to be aware is the County Council's draft budget is due to be released next Monday. We will have a particularly interesting job, so please everybody read it cover to cover, all 698 pages. James, work programme.
Thank you, Chair. It's the standard report. I hope it's fairly self-explanatory. To highlight a couple of specifics, Section 5, task and finish scrutiny activity. You referred earlier to the scrutiny work in progress on the Northamptonshire Highway Services contract scrutiny review, and the fact that that presentation of the final report will be deferred to the next committee meeting to enable further consideration of the best means of presenting that report as openly as possible. LGSS Joint Overview and Scrutiny Working Group. There is due to be an LGSS Joint Committee meeting tomorrow. So that was a salient factor in arranging the working group, so that may well now be possible to move forward on that. The overview of responses to previous resolutions is at the appendix, and everything is virtually where it should be. Happy to take any questions, Chair.
Any questions? No. None whatsoever, in that he's going to answer it anyway.
No, sorry, it was a separate point. So if there's no discussion on the general work programme, I will take the opportunity. And professionally, I'm kicking myself for needing to raise this now rather than when it should have been. But the item on earlier today, adult social care, the committee identified various recommendations. Broadly, reassurance about the current in-year budget position, asking the Cabinet to look at case studies of the proposed future approach being used elsewhere, and emphasising the need to be sure that results are delivered before any public money is used. Are they resolutions, or are they to be in a report to the Cabinet?
I don't care how you do it. They need to go to Cabinet, so yeah, but it doesn't need to be a 20-page report.
It certainly doesn't need to be a 20-page report.
Okay.
But it can be a shorter report.
All right, fine. We agreed
Thanks
with
for your
that.
confirmation.
Okay. In that case, thanks to everybody for attending. Once again, we've gone over time. Sorry about that, but everybody gets to say whatever they want to say. Thank you.